Welcome, students. Today, we are starting our journey into the brilliant, but sometimes, very fragile world of the human lung. In this session, we're going to kick off a deep dive into what happens when this very vital organ goes wrong. Okay, Chillet, let's dive right in. We're going to see how this absolutely amazing machine works, and this is more important for your future clinical practice, what happens when things go wrong. These concepts are absolutely crucial, so let's get started. First things first. To understand any pathology, we have to understand the normal histology, correct? So let's take a look at the healthy lung. All the way down to its microscopic engine room. Just look at this. What a beautiful structure. This, my friends, is the alveolus, the site of gas exchange. This is where all the magic happens, where the air you breathe in meets the blood. The whole purpose of respiration, it all comes down to this one thin, very delicate wall. Now, what's really interesting here are the key players in this whole drama. The type 1 pneumocytes, think of them as the thin walls of the house. They are essential for gas to pass through. And the type 2 cells? They are the maintenance crew. They produce surfactant, which keeps the alveolus open, and they can even multiply to repair damage by turning into type 1 cells. Very clever, no? So what happens when this structure fails mechanically? Before we get into all the complex diseases, let's just look at the most basic problems, the lung collapsing and the lung filling up with fluid. Atelectasis, please remember this word. You are going to see it very often. It's simply the medical term for a lung collapse. And this is a very, very serious problem because if the lung tissue, the parenchyma, isn't filled with air, then obviously no oxygen can get into the blood. And this slide, it illustrates the two main types you'll see on your wards perfectly. In resorption atelectasis, something is blocking the airway, right? So the air gets absorbed and the lung is literally pulled inwards. The mediastinum follows it. In compression, something from the outside, like fluid, is pushing the lung inwards. So the mediastinum gets pushed away. It's simple physics. Okay, the other basic failure is pulmonary edema. Essentially, the lung is drowning in its own fluid. Now, this can be caused by hemodynamic problems, typically left-sided heart failure, or by a direct injury to the alveolar wall itself. The lungs, they become heavy and just wet. Right. Now, building on that idea of fluid in the lungs, let's move to a true medical emergency, acute respiratory distress syndrome, or ARDS, as we call it. This is where the lung enters a catastrophic, vicious cycle of inflammation. So, the crucial point here, the point you must remember, is that ARDS is a rapid and severe lung injury. It's a storm of inflammation that causes non-cardiogenic pulmonary edema. In simple words, the lungs are filling with fluid, but it is not the heart's fault. The lung itself is under attack. This slide, it just shows everything. On the left, you have a peaceful, functioning alveolus doing its job. On the right, it is total chaos. Can you see the neutrophils, the immune cells, just rushing in? Fluid is leaking everywhere, and those delicate pneumocytes are dying. This is what we call the fatal cascade. It begins with some injury to the endothelium, which then calls in the neutrophils. But the neutrophils, in trying to help, actually cause even more damage, making the capillaries leaky. This floods the alveoli, and all the debris from the dead cells forms a barrier that makes breathing impossible. And here is the proof under the microscope. This is the pathognomic finding, meaning if you see this, you know it's ARDS. These thick, waxy pink layers you see lining the alveoli, those are the hyaline membranes, made of fibrin and debris from dead cells. And why is this so important to recognize? Because the mortality rate for severe ARDS can be as high as 46%. And that's even with the best modern intensive care we have today. It is a deadly, deadly condition. Now, let's shift our focus. From an acute crisis, we are moving to a slow, progressive battle. The chronic diseases that obstruct airflow, a group of conditions you will see every single day in your practice. To understand COPD, you absolutely must know this basic difference. A very simple way to remember it is this. Obstructive is an out problem. The air gets trapped inside. Restrictive is an in problem. The lungs cannot expand fully. Today, our focus is on the obstructive type.
COPD is a massive public health problem. It's really an umbrella term for diseases that are mainly caused by one thing, cigarette smoking. And it almost always involves two distinct pathologies working together, destroying the lung in different ways. So let's meet the two main culprits behind COPD, emphysema and chronic bronchitis. Now, while they often coexist in the same patient, especially a smoker, they actually damage the lung in very, very different ways.
On the screen here, you can see the gross pathology of emphysema. It is the irreversible breakdown of the air spaces. It destroys the alveolar walls and creates these large, useless air pockets. On the left, you see the centriacinar pattern, which is typical of smokers. The damage starts in the center of the lobules. On the right is the panacinar pattern, where the entire acinus is damaged. We often see this in a genetic deficiency.
Chronic bronchitis, on the other hand, is not an anatomical diagnosis, but a clinical one. This is a key point for your exams and your practice. It is all about the airways becoming inflamed and clogged up with mucus, which leads to that characteristic persistent cough.
And this table, it just brilliantly summarizes the classic clinical presentations. You have the blue bloater, the patient with chronic bronchitis who is struggling with low oxygen and a productive cough, and you have the pink puffer, the patient with emphysema who is thin, breathless, and fighting for every single breath by puffing their lips. Now, these are classic stereotypes, of course, but they really help you understand the underlying pathophysiology.
So this is the take-home message. Please remember this. One is a problem of mucus and inflammation in the tubes, in the bronchi. The other is a problem of the air sacs themselves, the alveoli, losing their structure and their elastic recoil.
So we've seen the pathology of acute and chronic lung failure. But all of this, it brings up a much bigger question for all of us, not just as future doctors, but as members of society. How do we protect these vital organs? That is something very important to think about. All right, class. Good morning, good morning. Let's get started. So today we are diving deep, really deep into the lungs. We're going to see what happens when that simple act of breathing, something we don't even think about, becomes a constant struggle, a daily battle.
I mean, have you ever really thought about it? Right now, you're breathing, I'm breathing. We do it thousands of times a day, and we don't even notice. But for millions of people, every single breath is hard work. So what is actually going wrong inside? What's the malfunction? So to figure this out, we're going on a tour. Think of me as your guide, and we're going right inside the lungs. We'll make 3 main stops to look at 3 major chronic diseases. Ready? Cello, let's go.
Okay, first stop on our tour. We're in the airways, the pipes, the bronchi and bronchioles. And here we see a battle happening. These passages are under siege. And the condition, as you all know, is asthma. Now, the first thing to remember about asthma is it's not just one thing. There are 2 main flavors, you could say. You've got your atopic asthma. This is the classic one, the allergic type. Think of kids reacting to pollen, dust. That's an IgE-mediated immune system overreaction. Then you have non-atopic asthma. Here, it's not about allergies. The triggers are different, maybe a bad viral infection, or even just breathing in polluted air. And this picture? My God, it shows you everything. Look on the left. That's a beautiful, wide-open, healthy airway. Plenty of room for air. Now look at the right. That is an asthmatic airway. It's like the body's security alarm is just blaring nonstop for no good reason. The walls are all swollen and inflamed, the muscle around it is squeezed tight, and look at all that mucus clogging it up. How is air supposed to get through that? It's a complete traffic jam. You see, if these attacks happen over and over and over again, the lung gets tired. It doesn't just bounce back to normal. No, it starts to change, for good. We call this airway remodeling. The walls literally get thicker. The muscles bulk up like they've been going to the gym. You get more glands pumping out even more mucus. And this damage is permanent. It's not going away.
So how does an asthma attack actually play out? Well, it's a 2-act play. Act 1 is the early phase. The trigger hits, pollen, whatever, and bam! Immediately, the muscles around the airway clamp down. That's bronchoconstriction. But the story isn't over. A few hours later, Act 2 begins, the late phase. This is when the real trouble starts. The inflammation kicks into high gear, and all these inflammatory cells, especially eosinophils, come rushing to the area, making everything much, much worse.
And after this whole battle, these eosinophils, they leave behind clues. Think of it like a crime scene. Under the microscope, we find these things called Charcot-Leyden crystals. These are basically the microscopic fingerprints of the eosinophils. When we see these in a patient's sputum, it's a smoking gun. We know for sure eosinophils were there, and we know what went. Okay, so asthma is all about narrowing that is, importantly, reversible. The airways tighten, but they can relax again. But
What if the damage is so bad that the airways don't just tighten? What if they get permanently wrecked, stretched out, and floppy? And that question leads us perfectly to the second stop on our tour, a condition called bronchiectasis. Here, the problem isn't tightening pipes. It's pipes that have been so damaged they've lost their shape entirely. They become weak and widened. Just look at this lung. This is what severe bronchiectasis does. It's the end result of years of infection and inflammation fighting it out. The airways are permanently stretched open, dilated. The best analogy I can give you is an old rubber band, you know? You stretch it too many times and it just loses its snap. It becomes a loose, floppy, useless thing. That's what has happened to these airways. So how does this destruction happen? Well, it's a truly vicious cycle. It starts with some kind of problem, maybe a really bad infection, or a genetic disease like cystic fibrosis, where the mucus is like glue. This blocks the airway. The blockage traps bacteria, leading to more infection. The infection causes inflammation, and the inflammation, well, it just chews up and destroys the airway walls. Obstruction, infection, inflammation, round and round it goes, getting worse each time. Okay, everyone, pens down for a second and listen up. This is a fundamental concept you absolutely must understand. The two diseases we just saw, asthma and bronchiectasis, are obstructive diseases. Think O for out. The problem is getting air out. Now we are about to see a restrictive disease. Here, the problem is getting air in because the lung itself can't expand. Obstructive, can't get air out. Restrictive, can't get air in. Got it? Somewhat gay? Very, very important. All right, for our final stop, we're going even deeper. We're moving past the pipes, the airways, and into the actual lung tissue itself, the scaffolding that holds everything up. And here we find a really nasty disease, idiopathic pulmonary fibrosis, IPF. The first word you need to focus on here is idiopathic. In medicine, that's just a fancy way of saying we have no idea what causes it. It's a mystery. But what it does, that's no mystery at all. It's a progressive disease where the soft, spongy tissue of the lung gets replaced by hard, useless scar tissue. So you're a radiologist, and you pull up a CT scan of a patient with advanced IPF. This is the sight that greets you. You see all these little cysts, these air pockets, especially at the bottom of the lungs. It looks exactly like a honeycomb. And when a radiologist sees this honeycomb pattern, their heart sinks because it's the classic, unmistakable sign of end-stage, irreversible scarring. So the CT scan shows us the honeycomb, but why does it look like that? Let's zoom in way down to the microscopic level. You see this slide? All that bright pink stuff? That's not lung. That's scar tissue. Dense, fibrous scar tissue that has completely wiped out the normal, delicate air sacs, the alveoli. The lung has lost its stretchiness. It's become stiff. And this is what we call the honeycomb lung. It is the final stage. There is no going back from this. It's a tragic, tragic transformation. Imagine a soft kitchen sponge slowly turning into a piece of concrete. That is exactly what happens to the lung in IPF. Okay, so that's our tour of the troubled lung. We've seen a lot. Now, let's bring it all together. This is the summary slide, the key takeaways. Very important for your exams and, more importantly, for your understanding. So let's break it down with this simple table. Asthma. The main problem is reversible narrowing of the airways. Bronchiectasis. It's permanent widening of those same airways. And idiopathic pulmonary fibrosis? Forget the airways. The problem is in the lung tissue itself, the interstitium, which is becoming scarred and stiff. Location and pathology, totally different for each one. So if you remember nothing else from today, remember this. This is the main funda. One disease, asthma, tightens the pipes. The second, bronchiectasis, destroys the pipes. And the third, IPF, turns the whole lung sponge into rock. Tightens, destroys, turns to rock. You remember that? And you'll never get these mixed up. And that brings us to the final big picture question. Right now, our treatments are mostly about managing symptoms, trying to make people breathe a little easier. But the real challenge, the one that I'm passing on to your generation of doctors, is this. How do we go beyond just managing? How can we find a way to actually reverse this damage, to heal the lung? That is the billion-dollar question. Okay, class dismissed.
Hello, everyone, and welcome. Today, we're going to dive into some really critical topics in lung pathology. And believe me, these are not just for your exams. These are the real cases that will walk into your clinics. So pay close attention and let's get started. First things first, just take a good look at this specimen. Can you imagine this was once a soft, pink, spongy lung full of air? But look at it now. It's become so hard, so dark, completely filled with this dense scar tissue. The whole normal architecture is just gone. So, this brings us to the big question, right? What is the process that can cause such a terrible, destructive change? I mean, how does a vital organ like the lung turn into this hardened, useless mass? Well, that is exactly what we are going to figure out today. Here is our plan for today. We'll begin with occupational dust diseases. Then we'll see what happens when the body's own immune system starts attacking the lungs. After that, we'll talk about some vascular emergencies. And finally, we will finish with some high-yield pathology pearls that will be very useful for your practice. Okay, so let's start with our first section. Here, we're talking about diseases that are a direct result of someone's job. What happens is, chronic exposure to certain tiny particles leads to a group of diseases we call the pneumoconioses. And the main problem in these diseases is fibrosis, or what you and I would just call scarring of the lungs.
So, who's the main actor in this drama? It's the pulmonary alveolar macrophage. Its job is to be the cleaner cell, gobbling up any dust we inhale. But when it meets these particular dust particles, it just goes crazy. It gets overactivated and starts releasing all these chemical signals that basically tell the lung, make scars, make more scars. So a good cell with good intentions ends up causing a very, very bad outcome.
We'll focus on the two big ones, silicosis, which comes from silica dust, and asbestosis, from asbestos fibers. Now, a very, very important point for your exams, please remember the locations. Silicosis loves the upper parts of the lungs. Asbestosis, on the other hand, it prefers the lower lobes. This distinction is a classic question, so don't you forget it. So let's come back to that first picture we saw. This is a perfect example of advanced silicosis. You can see it now, right? The damage, this hard, dark scar, is concentrated in the upper part of the lung. This is what happens when thousands of tiny nodules merge together over many, many years. It's really quite tragic. And if we zoom in with a microscope, this is what we see. This is the hallmark. Look closely at the center of the image. Can you see those pink collagen fibers? They are arranged in these swirling, concentric circles, almost like a fingerprint, no? That is the classic silicotic nodule. When a pathologist sees this, they know the diagnosis. Now, as future doctors, it's not enough to just diagnose. You need to know the risks. Patients with silicosis have a much, much higher chance of getting tuberculosis. And why is that? Well, the silica actually damages the macrophages and stops them from killing the TB bacteria. And on top of that, there's a twofold increased risk of lung cancer. These are deadly complications you have to be watching for. Okay, Cholo, let's move to our second occupational disease, asbestosis. What you're seeing right here is the smoking gun, the absolute proof. This is an asbestos body. It's basically an asbestos fiber that the macrophages have tried to coat with iron and protein. This gives it this classic golden brown, beaded, rod-like appearance. If you find this in a lung biopsy, the diagnosis is made. But, asbestos is tricky. It doesn't just damage the lung tissue inside. In fact, its most common sign is on the lining of the lung, the pleura. It forms these very distinct, dense, and often calcified plaques. You can see them here on the surface of the diaphragm. On a chest x-ray, these are a dead giveaway for asbestos exposure. Now this number should really make you pause. Asbestos exposure by itself increases the risk of lung cancer. Smoking, of course, we all know, increases the risk. But when you put them together, the risk doesn't just add up, it multiplies. It skyrockets by a massive 55 times. It's a truly frightening number. All right, let's shift gears now. We are moving away from diseases caused by outside dusts to a condition where the problem comes from within, our own body. We're talking about sarcoidosis, a systemic disease that is still one of medicine's great mysteries. This definition has all the important keywords. First, it's systemic, so it can affect many different organs. Second, we don't know the cause. And third, its hallmark is something called a non-caseating granuloma. Now, because the cause is unknown, sarcoidosis is always a diagnosis of exclusion. That means you have to rule out everything else that could cause granulomas, especially tuberculosis. And here it is, the hallmark lesion. A beautiful, well-formed granuloma. It's a tight ball of activated macrophages, what we call epithelioid cells, and these big multinucleated giant cells. But what's the most important word here? Non-caseating. It means there is no central cheese-like dead tissue, no necrosis. This is the key point that helps us separate it from the caseating granulomas we see in TB. So even though it's a systemic disease, the lung is its favorite target. In 90% of cases, the lung is involved. Classically, you'll see enlarged lymph nodes on both sides of the hilum. We call this bilateral hilar lymphadenopathy. There is also a very typical immune response inside the lung, with a lot of CD4 plus T helper cells. And please don't forget, you must always check the eyes and the skin, as they are also very commonly affected.
Let's move on to our third and final topic for today. So here, the problem isn't in the airways or the air sacs. The problem is in the plumbing, the blood vessels of the lung. We will discuss two big crises, blockages from blood clots and the problem of dangerously high pressure. So let's follow the journey of the most common culprit, a pulmonary embolus. In more than 95% of cases, the story starts far, far away from the chest. It begins deep inside the veins of the leg. A blood clot, a thrombus forms there. Now, if a piece of that clot breaks off, we call it an embolus. It then travels up through the veins, goes through the right side of the heart, and finally it gets stuck in the pulmonary arteries, blocking blood flow to the lungs.
And this is the most dramatic, most dangerous result. A huge embolus gets stuck right where the main pulmonary artery splits into the left and right branches. We call this a saddle embolus because it sits there like a saddle on a horse. By blocking blood flow to both lungs at once, it can cause instant death. It's a true medical emergency.
But not all these problems are so sudden. Sometimes, chronic issues, like having many small emboli over time, can cause the pressure inside the pulmonary arteries to get dangerously high. This is what we call pulmonary hypertension. And you can see here in the microscope slide, the arteries respond by making their muscular walls thicker and thicker. But this thickening only makes the vessel more narrow, which pushes the pressure even higher. It's a real vicious cycle.
Okay, we have covered a lot of ground today, haven't we? So to finish, let's just quickly summarize the most important high-yield points. Think of these as your pathology pearls, the key facts you must remember for your exams and for your patients.
This table really brings it all together. You see, pathology is all about patterns. For the occupational diseases, location is everything. Silicosis is upper lobes with that critical TB risk. Asbestosis is lower lobes with a major cancer risk. For sarcoidosis, think systemic, think non-caseating granulomas that can be anywhere. And for a pulmonary embolism, remember the story almost always starts far away, with a DVT in the leg. If you master these patterns, you are well on your way.
So what's the one thing I really want you to take away from all of this? It is this. In pathology, the pattern of injury tells the story of the disease. Upper lobe versus lower lobe fibrosis, caseating versus non-caseating granulomas. These are not just tiny details for an exam. They are the crucial clues that help you solve the puzzle for your patient. And this brings us to my final and most important question for you. A patient comes to you saying, "Doctor, I can't breathe." It's such a common complaint. But now, with this knowledge, how does recognizing these different pathological patterns change your whole approach? How does it help you ask the right questions, order the right tests, and ultimately get to the right diagnosis? Think about that.
All right, everyone, Cello, welcome. Today we are going on a journey deep inside our own lungs to see the massive battles they are fighting for us every single day, without us even knowing it.
You see, our lungs are our connection to life. Now, they bring in the air we need to survive. But this also means they're on the front lines, a constant battleground. A real Kurukshetra is happening inside. And the threats are not just from the outside world, but sometimes from our own bodies.
So, what's on the menu today? First, we'll see how healthy lungs protect themselves. Then we'll get into the diseases, the real problems, bleeding, infections, what happens when we need a whole new lung, and finally, we will face the biggest enemy, lung cancer.
So first things first, just think about it. With every single breath you take, what are you inhaling? Dust, germs, pollution. So how does the lung keep itself clean, yaar? How does it fight back?
So the body has a whole army, okay? A multi-level security system. The first guard is just a simple cough, Kansi. Then deeper inside, you have this escalator, the mucociliary apparatus, always cleaning, sweeping things out. And right at the bottom, in the alveoli, are the real soldiers, the macrophages. They just eat up the bad guys. And behind all this, of course, is the big boss, our entire immune system.
But what if your own soldiers start attacking your own foot? Kya hoga? That's what we call autoimmunity. And when this happens in the lungs, it's a disaster. It can cause dangerous bleeding inside the lungs. We call it pulmonary hemorrhage. Now this is a classic for your exams, bachchon. Good pasture syndrome. Just remember this name. What happens here is that our own antibodies, they go crazy. They start attacking the very foundation, the basement membrane of the lungs and the kidneys. So the attack is coming from inside the walls of the house itself. Now, look at this. Just look. On the left, you can see the fresh damage. Pura blood bhara hua hai in the alveoli. But the right side, oh, this is beautiful. This is a Prussian blue stain. All those blue dots, they are like footprints left behind by old battles. These are macrophages that ate up old blood cells, full of iron. We call them hemosiderin-laden macrophages. Very important Viva question. Okay, chalo, let's move on. Now we're talking about an outside enemy. Pneumonia. I'm telling you, this you will see every single day in your clinical practice. What is pneumonia? Simply, it's just an infection of the lung tissue itself, the parenchyma.
Now, it's very important to know the two main patterns, okay? One is bronchopneumonia. This is like patchy infection here and there. The other is lobar pneumonia, where the whole lobe, one entire section, becomes solid. Look at this diagram. See? It makes it so clear. On the left, bronchopneumonia. See the scattered spots? And on the right, lobar pneumonia. It's one solid block of infection. This picture tells you everything you need to know to tell them apart. Okay, so that was the drawing. Now see the real thing from the pathology lab. On the left, that's what patchy bronchopneumonia actually looks like. And on the right, see how that whole lower part is dark and solid? That is classic lobar pneumonia. You have to burn this image into your brain. Now, lobar pneumonia has a story. It goes through 4 classic stages. First, congestion. The lung gets heavy and wet. Then, red hepatization. It becomes red and firm, like a liver. That's why the name. Then, gray hepatization, as the red cells die. And finally, hopefully, resolution. Everything gets cleaned up. It's a step-by-step process. But what if the infection wins? Then you get this, a lung abscess, a very serious complication. Look at it. It's basically a hole filled with pus and dead tissue. Necrosis. The lung is literally getting destroyed. This is why we hit pneumonia hard and fast with antibiotics. Now, for some patients, when the lungs are completely finished, the only option left is a transplant, a new set of lungs. But, this is not a simple fix. It brings its own very big problems. After the transplant, the patient is fighting a war on 2 fronts, okay? 2 main enemies. First is infection. Why? Aryake? Because we have to suppress their immune system with drugs so they don't reject the new lung, so they can get any infection easily. And the second enemy? Rejection itself. The body's immune system is smart now. It says, hey, this is not mine, and it starts attacking the new lung. And this is the biggest problem in the long run, chronic rejection. And it has a name you must remember, bronchiolitis obliterans. What is it? Basically, the tiny airways, they get scarred and blocked, completely closed off by fibrosis. And this damage is permanent. A huge, huge challenge for doctors. And now, for the final section, we come to the biggest monster of them all. This is not an outside invader. This is not your own body making a mistake. This is a rebellion from your own cells. We're talking about lung cancer. When we talk about lung cancer, there is one number that tells you almost the entire story, 80%. What is this 80%? That's the percentage of lung cancers that happen in smokers or people who just stopped smoking. The connection is, it's not even a question anymore. It is direct, clear as day. And just to show you how big this problem is, just listen to this. Every single year, lung cancer kills more people than colon, breast, and prostate cancer put together, combined. It is the #1 cancer killer in the world, no doubt about it.
So, today we've seen everything, na? The lungs fighting invaders, fighting themselves, and even fighting their own rebellious cells. After all this, the evidence points to one very, very clear answer about the single best way to protect these lungs. The most important battle for our lungs is not fought by doctors in a hospital. It's fought by each one of us with the choices we make every single day. ठीक है? Chalo, thank you everyone.
Hello, everyone. Today, we're going to tackle a really, really important topic for all you future doctors, the pathology of lung cancer. We're going to break down how this disease starts, what it looks like under the microscope, and most importantly, how all of this affects the patients you are going to see. So let's get right into it, shall we? So let's start with the most basic question, the why behind it all. I mean, what is the process that takes a perfectly normal, happy lung cell and turns it into a rogue agent, a killer? Let's try and figure this out together. Here's our game plan for today. We'll start with the triggers, the outside and inside forces. Then we'll take a deep dive into the genetics. After that, we'll identify the 3 big players, the major types of lung cancer. We'll see their early warning signs, and then we'll connect everything back to what you will actually see in a patient. Right, first up, the triggers. You see, to understand any cancer, you have to start with its cause, its etiology. So what are these forces that are constantly attacking and damaging our lungs? Now, this isn't just some list of chemicals you have to mug up for your Viva. No. Each one of these, asbestos, arsenic, chromium, is a potential clue. This is exactly why you have to ask about a patient's job history. Are they a miner? Do they work in a factory? I'm telling you, this information is vital for your clinical practice, not just for passing exams. And this number beautifully illustrates a critical concept, synergy. Just look at this number, 55 times the risk. An asbestos worker who doesn't smoke has about a 5 times higher risk. But you add smoking to that, the risk just explodes. It's not addition, it becomes multiplication. This is a classic exam question, so please remember this one. Okay, so let's see how all this damage from the outside world actually translates to what's happening inside a single cell. Because this, my friends, is where the real fight for control begins. This is the world of modern molecular pathology. You know, it's really important to understand that not all mutations are the same. Some are just passengers, kind of just along for the ride. But a driver mutation, this is the one that puts the foot on the accelerator. It's that one key mistake that sets a cell on the terrible path to becoming a cancer. Just think of it like driving a car, okay? Your cell has controls to keep it safe. Tumor suppressor genes, like TP53 and RB, these are the brakes. So a mutation here is a loss of function. Basically, the brakes have failed. Then on the other hand, you have oncogenes, like EGFR and KRAS. These are the accelerators. A gain of function mutation here means the accelerator is stuck to the floor. Cancer happens when you lose the brakes and the accelerator is jammed. Simple, nah? Okay, so we've looked at the why, the triggers, and the genetic mistakes. Now, as pathologists, our job is to identify the what. What does this cancer actually look like? Come on, let's meet the main culprits. Now, have a look at these numbers. You know, for a long, long time, squamous cell was the king, especially in smokers, but things have changed. Now, adenocarcinoma is the most common type you will see, making up half of all cases. It's even the #1 type in non-smokers. This is a really significant shift you need to be aware of. Okay, let's get practical. On the left, you see the gross specimen. Adenocarcinomas are typically found on the periphery, out in the lung tissue itself, and they often have this scarred, puckered look. And on the right, under the microscope, what do you see? Glands. Beautifully, horribly formed glandular structures. Adeno means gland. That's your clue, right there. So the key things to remember for adenocarcinoma are, it's the most common type, even in people who have never smoked. Microscopically, you'll see glands or mucin, and it stains positive for a marker called TTF1. And this is crucial. It's often linked with driver mutations like EGFR and ALK. This is so important because now we have targeted drugs for these specific mutations. This is pathology directly guiding patient treatment. Now let's compare that with squamous cell carcinoma. See the difference? On the left, the gross image shows a central mass coming from a major bronchus near the hilum. This is classic. And on the right, this is the money shot. That pink swirly thing is a keratin pearl. If you see this, you can be 99% sure you are looking at squamous cell carcinoma. It's a dead giveaway. So to recap for squamous cell, this type has the strongest link to smoking. The key features are keratinization and those little intercellular bridges, those connections between the cells. It usually pops up centrally and is preceded by squamous metaplasia and dysplasia, which we'll look at in a bit.
It's the direct result of years of tobacco smoke just irritating the bronchial lining. And now for our third major type, small cell carcinoma. Just look at these cells. They are small, dark blue with very little cytoplasm. Pathologists often say they look like crushed oats. And notice how the nuclei are kind of molding against each other? And that dark purple stain on the blood vessel? That's the Azzopardi effect. It happens because these fragile cancer cells die so fast that their DNA leaks out and sticks to the vessel walls. These are all classic signs.
I'm telling you, this is the most aggressive of them all. It's almost exclusively found in smokers. It shows neuroendocrine differentiation, which means it can produce hormones, leading to something called paraneoplastic syndromes. That's a favorite exam topic, by the way. It spreads very, very early. And genetically, you'll see that both TP53 and RB are almost always inactivated. The brakes are completely gone.
You know, it's so important to remember that cancer doesn't just appear overnight. It's a step-by-step process. So let's look at the stages before it becomes a full-blown invasive killer. These are the early warning signs. And this image brilliantly illustrates the path to squamous cell carcinoma. On the far left, you have normal, happy bronchial cells. Then, constant irritation from smoke causes squamous metaplasia. The cells change their type to protect themselves. But with continued attack, you get dysplasia, which you see in the middle. Look at the chaos. The nuclei are dark, they're disorganized. Finally, on the right, you have carcinoma in situ. It's cancer, yes, but it hasn't broken through the basement membrane yet. This is the last stop before a full-scale invasion.
Okay, we've seen it all. The cause, the genes, the types, the early stages. Now let's connect all our pathology knowledge to the real world. How will your patient actually present to you in the clinic? What symptoms will they have?
This table is pure gold for your exams and for your wards. It directly connects the symptom to its pathological reason. Why does the patient have a cough or blood in their sputum? Because the tumor is in the central airways. Hoarseness in their voice, the recurrent laryngeal nerve is being invaded. Superior vena cava syndrome, the tumor is pressing on the SVC. You see, each symptom tells a story about where the tumor is and what it's doing.
And now, look at these bars. This is why our work, and your future work, is so incredibly critical. If we catch the disease when it's localized, the 5-year survival is over 50%. It's not great, but there's a good chance. But once it spreads to the regional nodes, that drops to 22%, and with distant metastases, it's only 4%. This starkly shows why staging and early diagnosis are absolutely everything in lung cancer. All right, let's quickly recap the absolute must-know points. Adenocarcinoma is now number 1, even in non-smokers. Squamous and small cell are the smokers' cancers. Early detection is a matter of life or death. Small cell is the most aggressive, but does respond well initially to chemo. And for adenocarcinomas, we now have targeted therapies based on the specific driver mutations we find. This is the very essence of modern oncology. After all of this complex pathology and genetics and everything we've discussed, we must never, ever forget the simplest truth. The very best treatment for lung cancer is and always will be prevention. Stopping smoking is the most powerful weapon we have against this horrible disease. And I want to leave you with a question to think about. We've talked so much about molecular markers and driver mutations. As our genetic tools get more and more powerful, do you think there will be a day when we don't need the microscope anymore? Will a gene sequencer replace the pathologist? It's something to think about as you move forward in your studies. Thanks for your attention.
Hello, future doctors. Today, we're going to dive deep into a very important and, frankly, a very dangerous tumor, malignant mesothelioma. It's a really complex diagnosis, one that every single one of you needs to be able to recognize. So, let's break it down step by step from the moment a patient walks in all the way to the final lab report.
All right, so here's our plan for today. Think of it as a diagnostic journey. We'll start with the clinical problem, what we call a deadly sheath. Then we'll look at the big picture in the lab. After that, we'll zoom right into the cellular chaos under the microscope, find the decisive stain, and finally, we'll wrap up with the prognosis and some key facts. Ready? Let's begin.
You know, every diagnosis we make doesn't start in a lab with a slide. No, it starts with a person, a patient. So our first job is to understand the clinical signs. What are the symptoms that bring a person to the clinic and should immediately make you think, could this be mesothelioma?
So, let's just start with this central question, shall we? What exactly is this disease? What is this thing that so aggressively attacks the pleura, the lining of our lungs? By the end of our discussion today, you'll have a very clear answer. Typically, the patient will present with a classic triad of symptoms. You have to remember this. First, persistent chest pain. Second, dyspnea or shortness of breath. And third, something we call recurrent pleural effusions. That's fluid that just keeps building up in the chest again and again. When you see these three together, mesothelioma has to be high on your list of possibilities.
Okay, so we've moved from the clinic and now we are in the pathology lab. A sample has been taken. So what does this tumor actually look like to the naked eye? This is what we pathologists call the gross examination.
In this image, wow, it's really striking, isn't it? Look closely. This is not some single round tumor that you can just cut out. No, it's a thick, suffocating blanket of firm, white tissue that completely wraps around or ensheathes the entire lung.
So the key takeaway here, the word you must remember, is diffuse. The tumor spreads like a sheet, you see. It just coats the entire surface and invades anything and everything that is nearby. And this diffuse growth pattern is exactly what makes it so incredibly difficult to remove with surgery.
Great. So we've seen the clinical picture and the gross specimen. Now let's zoom in. Let's zoom in much, much further, down to the cellular level. It's time to go under the microscope.
Now, to understand what we're about to see, you have to know about the cell where it all begins, the mesothelial cell. This cell is quite unique. It has a kind of dual nature. It can grow into cells that look like epithelium, the kind that line glands, or it can grow into mesenchymal cells, the kind that form connective tissue. This duality is the absolute key to understanding everything else.
This special dual nature of the cell leads directly to three main macroscopic types. And as you can see from the chart, the vast majority, we're talking 60 to 80% of cases, are what we call the epithelioid type, where the tumor cells are mimicking the epithelium.
And this is what that epithelioid type looks like under the microscope. See how the cells are forming these tube-like or papillary structures? Now here's the critical part, the big challenge for us. This pattern can look almost identical to lung adenocarcinoma. This mimicry is a huge diagnostic trap.
Then, on the complete other end of the spectrum, we have the sarcomatoid type. In this one, the cell's mesenchymal side takes over. The tumor cells are long and thin, they're spindle-shaped, looking much more like a fibrous tumor, or sarcoma. It's a totally different microscopic world.
And finally, there's the biphasic type, which, just as the name suggests, is simply a mix of both patterns. In this image, we've used a special stain, and you can clearly see the epithelioid parts are staining a strong brown, and they're mixed right in with the unstained sarcomatoid areas.
So, this brings us to the most critical question in diagnosis. If that common epithelioid type looks so much like adenocarcinoma, how on earth do we tell them apart? Well, the answer lies in modern pathology, using a technique called immunohistochemistry, or IHC, to find a specific molecular fingerprint. Okay, now pay very close attention to this slide. It's extremely high yield for your exams. This is the panel of antibody stains that helps us make the distinction. It's simple, really. Mesothelioma is positive for calretinin and WT1, but it's negative for adenocarcinoma markers. And adenocarcinoma, it's the exact opposite. This is the molecular fingerprint we were looking for.
And this, my friends, is the most important principle in pathology. A diagnosis is never, ever based on just a single test. It's a combination of everything: the clinical symptoms, the gross appearance, what we see under the microscope, and this IHC panel. All of it together leads to a definitive answer. This is what we call clinical pathological correlation.
Let's conclude now by looking at the reality for the patient. What is the prognosis, and what are the final key facts we need to remember to complete our picture of this disease? I just want you to look at this number for a moment. Just take it in. It tells a very grim story about just how aggressive this disease really is.
So, what does that 50% represent? It means that half of all patients who are diagnosed will die within 1 year. The prognosis is, unfortunately, incredibly poor, and this is precisely why an early and an accurate diagnosis, which is your future job, is so absolutely critical. And finally, just a few key facts to round out our understanding. First, the disease often spreads to the hilar lymph nodes and the liver. Second, it can also show up in the peritoneum, in the abdomen, not just the chest. And third, and this is quite interesting, while we always link this cancer to asbestos, only about 20% of patients will actually have the lung scarring that we know as asbestosis.
So, let's come full circle back to our main question. What is the key takeaway here? For your exams, and more importantly for your future patients, it's all about remembering the entire pathway.
From that classic triad of symptoms to the diffuse white sheath you see on the gross specimen, through the different microscopic variants, and finally to that decisive IHC panel for confirmation. Mastering this entire diagnostic journey is absolutely essential.